Good morning to everyone. Welcome to this webinar Wednesday. It is with true pleasure that my brother Alessandro and myself will spend with you the next hour talking about digital dentistry and especially speaking about how to manage simple and complex cases in this new digital era. Before to start, we want to thank all Team Atlanta, Eddie, Henry and Maurice Salama, David Garber for having us here once again in this wonderful website, Tyler, Pana, Ariel and all the Dental XP staff for helping us in editing this webinar. And I want to remind you also not to miss the next XP Global Symposium that is going to be held in Miami the next June. One thing that I think is important for you to know is that you still have 1 month to early register to the event in order to get 2 free hands-on courses. Talking about our webinar, the goal of today is to understand when, where, how and why are the new technologies entering in the treatment plan process both from a clinical perspective and from a technical point of view, because we know that nowadays we have tools that are helping us as clinician but are helping us also our technician to be more predictable and more precise. We spoke already about the Intra scanner, the ZFX Intra scanner, and here you can find a summary of all the characteristics of the intraoral scanner that we discussed about in the first part of this webinar. The thing that is important for you to know and to remember is that it's working with a confocal microscopy. It has the possibility to, and it has the copyright to of the real-time stitching. That is really important, and we're gonna see why later on the day. Is important because you have to know that it is possible to scan the soft tissue without the need for additional powder. You can start and stop the scan at any time you want. Inside of the intraoral scanner you can find a gravity sensor that is helping us not to lose the orientation while scanning, and I think that the weight of this tool is not too much and is easy to carry in between 2 offices. If you have 2 offices like for example we have. More and not less important is that it's an open system to all major dental CAD on the market. And as I told you, all of these characteristics are described in details in the first part of this webinar that has been done in the 27th of March of this year, in where we were also describing and talking to you about our ZFX experience so far on natural dentition, simple cases in maximum intercuspation. What we're gonna do today is to focus our attention in single edentalism and more specific case till arrive to the big cases and full arch rehabilitation. And we're gonna see how the new technologies are entering in our treatment plan process in all of these kind of cases. So let's now start with the single edentalism, and we use this system with different implant surfaces, designs and diameter, and we think that the system helps the clinician and the technician in a very big way and gives you a lot of benefits. Let's take for example this kind of cases that entered in our office in 2012. Was a female patient, 43 years old. She was referring pain on the upper left side when she was chewing. As we always do, we take pictures not only from the vestibular point of view but also from the occlusal point of view, because we want to monitor all the aesthetic area at 360 degrees. We start to collect information as for example the digital x-rays, and we saw from it that the patient was suffering of a fracture root under this crown. So we kept on collecting information to achieve the correct diagnosis. So we want to know which kind of socket type we are in, which kind of biotype we have in front, and if we had interproximal loss height of the bone. To do this, we do the bone sounding, with a little bit of anesthesia of the patient, and we found that we were in front of type 1 socket with thin biotype, and our decision was to go for immediate implant placement and loading. Of course, in this kind of cases, it's very important to evaluate different parameters. For example, you have to evaluate the bacolingual contour change, the soft tissue thickness, and the tissue discoloration if you want to achieve an 100% aesthetic result. And you have to ask yourself some questions, as for example, one that we think is really important is to understand if it's important to place a bone graft, a connective tissue graft, or both in the jumping distance. Because of course we know that when we extract a tooth and we place an implant, the socket has an oval shape, while our implant has a round diameter and a round shape, and so we will always have this gap, this jumping distance, that we have to understand how to treat. And to understand this, I think that it's important to underline the great work that has been published by Team Atlanta and Team New York together last July in the compendium, in where for the first time it has been described what is the dual zone socket management, that was dividing this area in the bone zone, that is everything that is under the neck of the implant, and the tissue zone, that is everything that is above the neck of the implant. And where they starting to collect information and collect data on the facial palatal contour change, on the peri-implant soft tissue thickness, and on the gingival tissue discoloration, that are exactly the three parameters that we think that are important to know in these kind of cases. And in the data that they give us, and in the data that also Stephen Chu presented on a webinar on Dental XP, we can see that they divided their patient in three groups. First group in where they were just extracting the tooth and placing the implant. The second group in where they were extracting the tooth, placing the implant, and placing the temp at the same time. In the third group in where they were extracting the tooth, placing the implant and the temp, but also packing some bone graft in the jumping distance, in the gap. What they found is that by looking at these three groups, both in the tissue zone and in the bone zone, they noticed some big changes, especially in the third group. So in the group in where they were using both the bone graft and the provisional. In fact, you can see that in the bone zone, they achieve almost 1 millimeter, and in the tissue zone, they achieve almost half of a millimeter compared to the first two groups. So the important thing is to understand which are the roles of the provisional and of the bone graft in these results. And in this study, they were not discussing about connective tissue graft, and they were not even discussing about and giving like a distinction of the gingival biotype. And they were concluding by saying that in patients with a thin periodontal phenotype, most probably an additional surgical intervention was required to remediate the surrounding soft tissue architecture before, during, or after the implant placement. And by looking at the literature, also Yuri Grunder did a study about the connective tissue graft, in where he was measuring the implant head 3 mm from the free gingival margin, and he had like two groups, a control group with 12 patients in where he was not placing the graft and he was not placing the provisional, and he had a volume loss of 1 mm, and I want to underline volume, so he was looking at the bacolingual contour change. And in the second group, there was the test group with 12 patients as well. He didn't place the provisional, but he placed the connective tissue graft, and he had a volume gain of plus 3 mm only by placing the connective tissue graft. So by looking at this literature, together with Maurice and Henry and David Garber, we decided to start collecting data on this surgical protocol that we define as the overbuilding of the site, in where After an automatic extraction of the tooth and a correct placement of the implant, that in this case is a trabecular metal implant. Of course, the position of the implant is important. It has to be placed in the correct 3 dimension of the socket, not only mesiodistally but also apicocoronally and baccolingually. And of course, we have, as in the picture in the middle is showing you, a gap to manage. And in this protocol, we think that it's important to place a connective tissue graft, and you can see here with a partial thickness flap with the U suture points that we're gonna see more in detail in a bit. And after that we place the connective tissue graft, you can see that we can position an healing abutment and packed some bone graft all over the socket. The peculiar part of this protocol is the connective tissue graft management, and so what we do is always routinely to go and measure the harvesting site, the donor site, and try to understand before how much tissue from the palate we can get. And we know that this kind of tissue sometimes can resorb, so we try to avoid and to compensate the resorption of this tissue by double thickening it before placing it in the socket. And then you can see here in a step by step how we place the connective tissue in position. Is a partial thickness flap. We do a simple envelope. Remember, it's a partial thickness flap. That is very important, not a full thickness flap. And then with a U suture you can get the tissue inside the socket, inside this little envelope that we created, and then you can just close the suture, and you have your connective tissue in position. Of course, it's not important only the surgical part, but also the prosthetic protocol of smoothing and shaping the provisional with the correct shape. It's very important. It's very important, yes, for this kind of protocol, but it's very important spending time in doing a correct provisional, especially if you are thinking to go for a digital solution, because we will see later on in the processing of our files how important is a correct shape of a provisional. Here you can see that we always protect the socket with a rubber dam while we are relining the temp, and then we spend time in smoothing and shaping in the correct way the provisional, because we know that from Weisgold article we know that we have a subgingival contour of the crown that has to be concave and not convex to provide excellent soft tissue support without pushing the facial gingival apically. And this is critical because we want always at the end of our restoration that white and the pink that are blending together and are helping us in giving the patient a beautiful restoration. And if we don't spend time and we don't know how to manage the prosthetic shaping of the temp, it won't happen. And you can see here at T0, so before we before we touch the patient, and compared to T1 that is exactly the same day but after the surgery, after the overbuilding of the site, and at T2 that is at 1 week follow-up, you can see how the tissue is creeping on our provisional, how the tissue is adhering, how everything is blending together for our final provisional restoration. And this is the scenario that you want to see when you unscrew for the first time the temp. This is the 3-month follow-up, and you can see how thick and robust is the tissue and how the implant has been positioned in the correct way. And you can see that you have a good vertical soft tissue eye that is critical for the long-term prognosis and the long-term survival of your restoration, and also for the aesthetic of your restoration, because you want to give space to your technician to create a nice emergence profile to your final crown. And yes, we are talking about, we are inside a digital webinar, so right now we are ready to take the impression, and we decided to go for a digital impression. In order to take a digital impression, we have these match holders that are basically digital impression copying, that are helping us because are indicating the apical coronal position and the implant head indication. They are oriented guide to the internal X that is perpendicular to the long axis of the match holder, but one thing that I want to point out is that they fit perfectly without any tolerance, and this is one of the big advantage that the digital solution are giving us, especially in the implant solution. We are basically eliminating all the prosthetic tolerance that we have in the traditional protocol. Here you can see on the picture on the right the match holder in position, and you can see how we did not have any shrinkage, how we did not have any collapse bacolingually speaking, and also how you can see how we manage and how is the overbuilding still in place. And this is what we want to see when we are approaching our impression, that can be traditional or digital, that doesn't matter, but what you want to see is that clinical scenario. Is important and is written in the literature that you have to have a strategy of scanning, because if you don't have a scanning strategy, you're gonna put errors inside your scan and you're not gonna be accurate in your final restoration. So it's very important, and you can see here Alessandro that is taking an impression with one of our assistants. It's very important to have in your head a protocol, and the protocol that we have every time that we take a digital impression is based on 3 steps. The first one is where we define the target area, so in where we define the limits of the acquisition area around our preparation or our implant, and of course we want to make sure that we're going to include all the areas and the spot and all the information that the lab may need. In the second step that we call the overall scan, we're going to start our acquisition, and we're going to do some smooth, nice and easy movement, and we're not going to worry about some black holes, because those are the holes that in the step 3 are going to be closed in the step 3 that we call checking and finish. And of course, one of the advantage that if something is look wrong, and if we don't like something that we're doing, we can always restart our scan from scratch, and we can take all the areas or the information that we lost in the scan. So it's very important, and it's very easy, and it's not time consuming at all. But the important thing, the critical thing, is that you have to have a protocol also of scanning. You have to have a scanning strategy. That is very important. So let's see with this short video exactly how was that digital impression of that day. You can see from the beginning that everything is digital. What we are doing right now is like a digital prescription. What we usually do on paper, we can do it on the computer. We can define our target area. That is exactly what we are doing right now. You see, by choosing anatomic copying, we are choosing the material that we want the restoration. We are choosing the color. We are choosing how many scans we have to do. We are choosing custom abutment. As you can see, we want custom abutment with titanium core inside, so we are gonna place it and choose it in the digital prescription. Then we can write some notes as we are doing right now, and we are remembering the technician that we want our abutment in zirconia, but with a titanium core inside. Then what we're doing right now is defining the target area, and by simple clicking the tooth number and copy and paste them, you can define the target area, you can define the opposing dentition, and you can define the bite. That is very important. Then one thing that you have to do is to save everything, because without saving you cannot go forward. If it's the first patient of the day, you can calibrate the scanner just by clicking this button, and then you have the wizard on the left side that is always helping us and is always telling you what to do. We can take the powder that, as I told you at the beginning, we can also not using it. We use it only because we want to be faster while we are scanning. Then we take the intraoral scanner in our hands and we start doing this nice and easy movement. You see, we're very slow movement, and this on the left side is the clinical part, and on the right side you see what we see exactly on our screen, on our computer screen, the 3D model that is generating. You can see all the different colors that have been described also in the first part of the webinar. You can see on the top right the green frame is telling you that you are doing correct and that you are scanning in the correct way. Then we want to lighten the file, so we want to cut the unuseful data exactly as we are doing here, and you can see the wizard is always on your left telling you and suggesting you what to do. Then you can post-process immediately your scannerization. You can check it once again, and when you're happy with it you can move on. Again, the wizard is helping you on your left side. Then we go, and we still have the provisional in the mouth, so we go for the opposing dentition. You can see how important are also those orthoretractor that are not hurting the patient, and you can see here opposing dentition, slowly movement, defining the target area. This is the 3D model that is generating. You can see all these different colors. The green are the colors that have been already acquired. Here we are cutting some unuseful part, and then we can move on. Now we can unscrew the temp and take the soft tissue channel impression. We can spray a little bit of powder again, and once again slow movement, defining the target area. 3D model on the right side that is generating. You see orange points are the points that are just have been acquired to the software. The blue frame are the points that you are not inside the scannerization at that moment. And here I want to show you how precise is the system. Here I'm gonna put this picture on the right side and I'm gonna compare it to the clinical picture. You can see that it's basically the same. Very impressive. Then we place in position the digital impression copying, so the mesh holder. You can see here also on the video clinically how nice and robust is the tissue after the overbuilding of the site protocol. We place the powder once again, slow movement, and this is exactly what you are seeing in your screen. You see on the top right still the green frame that is telling you exactly what you're scanning. Then here you can twist and roll it, and roll the scannerization and see if everything is correct. And here is another advantage of this system. You can take out the temp and scan the temp, because we know that once we unscrew the temp the tissue tends to collapse, but acrylic resin does not collapse. And so here we are exactly giving to our dental technician the shape of our soft tissue. And you can see here, this is why it's so important to spend time while you are shaping and smoothing your temp chair side, because here you're gonna get all the benefits of that day. Of course, it's important to finish the scan, taking the bite, registration. It's very easy. You can see always these orthoretractor that are not harming the patient, the wizard on the left side, and here the bite that it is generating, the 3D model that is generating little by little, the black holes that are getting filled, and the more we go on, the more the 3D model is generating. Then we go to the CAD evolution, so the technical process. These are all the things that our dental technician can do. You can see, can define the finishing line of the abutment just by choosing the points, and you can see here that the computer is giving him some suggestion, and he can change it until he's not happy with them. And you can see the wizard is always on the left side. You can change from the vestibular to the palatal part as he wants, as he thinks that is correct. And here is very nice because you can see how the traditional knowledge of our dental technician is blending together with all the new digital possibilities. He can play with the soft tissue tunnel, and he can play with the emergence profile of his abutment, and he has always everything under control, the screw hole axis. And here is what he's doing is just matching our temp to the temp of the library software. And that's why, once again, it's important to spend time in doing your temporary. You can see here is matching it, and then he's placing inside again the software, and you can see he has everything under control. Look at this screenshot. Opposing dentition, sagittal view, the soft tissue tunnel view, everything is under his control. He can decide which kind of finishing line give to his abutment. He can decide all the width and everything. He can always have he can always have all the parameters under control, and he can put his knowledge, his traditional knowledge, in building this peculiar framework. You can see that those framework has a peculiar forms, a peculiar shape, because it is using our dental technician, that in this case was Matteo Dondi, that is Luca Dondi's son, is using the zirconia characteristic to our advantage. He knows where are the weaker areas, and he is going, with the shape of the framework, is going to increase the strength of the framework, and increase the strength of the final restoration. This is really important, because what we want are restoration that are surviving at 3, 4, 5, 6, 10 years. This is our goal. It's not important the T0. For us, the T0 is when we screw or when we cement the final restoration in the patient's mouth. And the T1, it has to be at 1 year, T2 at 2 years, T3 at 3 years, because we need to have a long-term predictability. We need to have a long-term survival rate of all our restoration. This will increase patient quality of life. And you can see here how precise is the software and how precise is also the milling center. And in this case, you can see that we had the possibility to have both the abutment and the framework milled, because we had at least 1 millimeter of length on vertical soft tissue height. And so for milling strategy, we had, in this case, the possibility to have both the abutment and the framework milled. And you can see from this view the concavity that has been designed at the software to manage perfectly the soft tissue. So every detail has been studied from the clinician and also from the technician perspective. This is really important. And here, going back to the clinician and going forward with the treatment plan sequence, you can see all the try-in, and you can see the final restoration in place, always from an occlusal point of view, because we wanted to check the buccal lingual contour, and we saw, and you can see also that there is no change in the buccal lingual dimension. You can see also the X-rays of the trabecular metal in place. And this is the 1 year follow-up, the before and after of this nice restoration done by Luca Dondi. And from the CT scan evaluation at 1 year, you can see how we managed to increase this buccal dimension. And you can see not only that, but you can see also the peculiar shape of the final restoration, the subgingival contour, the critical contour, the subcritical contour, how the trabecular metal implant is working well inside the bone of our patient, and how everything, white and pink aesthetics, are blending together to the success of our final restoration. And this is the biotype at T0 when the patient entered for the first time in our office. You can see it was a clearly a thin biotype, and here you can see at the end of the restoration we managed to change the biotype from thin to thick, and the literature is telling us that this kind of protocol are working well, because also Joe Kahn is in one of his latest article in 2012. He was doing a test control study in where he was placing where he was not placing a connective tissue graft in one group, and in where he was placing a connective tissue graft in the second group. And what he discovered and what he described is that in the yes graft group, at the T2, that is the final restoration, he had like more than 2 millimeters thickness from more than 2 millimeter distance thickness of tissue. And this is very important also if we remind the Jung articles in where he is giving 2 millimeter as a threshold to not have the perception of what is underneath the tissue, so to camouflage as much as we can the abutment and the implant underneath the tissue. So we think that this protocol is working. We are collecting data in this multi-center study. Here you can see some of the cases that are inside the study. There are also cases of Maurice Salama in this line. And of course we are collecting data, and we presented the preliminary data at the American Academy of Periodontics in Los Angeles in 2012. And so far we had 24 patients, 14 female, 10 males. The mean age were 46 years old, and the mean follow-up is 1 year. Of course it's very important to define that we are in type 1 Socken and thin biotype patient. That I think is very important to underline once again. Those are all the data from T0 to T4, that is 1 year after the surgery. And if we do like a little graph, you can see that in the tissue zone we managed to have a big result from our perspective, because we managed to have a 0.6 millimeter gain. That is exactly where the tissue zone where we are placing the connective tissue graft. So we are thinking that probably the connective tissue graft is really working in these kind of cases. Of course, you have to diagnose them correctly, and you have to carefully perform all the single procedure from the surgical protocol to the prosthetic protocol very carefully to achieve this kind of result. And in the bone zone we had like a minus 0.3, that is more or less comparing to what Stephen Chu, what Team New York and Team Atlanta achieved in their dual zone study. So let's now move on and see how the digital solution, how the new technologies are entering in the treatment plan of more specific cases and full arch rehabilitation. So let's take for example this patient, female patient that entered in our office at the beginning of this year, and as you can see she was suffering of molars with furcation involvement, so periodontal disease, and the treatment plan that we decided for this patient was to treat her in a periodontal way with hemisected root, and together combined with a osseoresective surgery. You can see here all the steps of the surgery, from the beginning to the flap elevation to the suture until the soft tissue healing. In fact, in the picture on the right you can see the tissue that are healed, and we already spray some powder and we are ready to take the digital impression. This treatment plan has been is following one of the articles of Gianfranco Carnevale, in where with this kind of procedure in 10 years longitudinal study, he had a 93% survival rate of this root treated in this way. And of course it's important diagnose them correctly at the beginning, understand where to intervene, and of course carefully perform every single step of the procedure, especially starting from the temporary, because as I was telling you before, in the digital era a big important is done by the temporarization, and this means that you have to spend time and you have to speak with your dental technician and shape and smooth correctly your provisional restoration, because it can be very helpful. Let's take for example this case in where we place the provisional in place to our patient. We wait for the soft tissue healing after the surgery, and we left the patient functionalize by herself our provisional. Once she functionalized and she customized her provisional, we scanned them, and in this way we have a perfect replica of the function of our patients. Digital solution, and especially digital intraoral scanner, it's important, and I think it has a big advantage in this kind of cases, because also even if we are in a posterior areas, thanks to the 45 degrees laser beam of our scanner, it's easy for us, if we have a correct scanning strategy, to achieve those type of scan. And you can see here how the picture is very well defined, how we can by ourselves customize the finishing line, since we are working in with vertical finishing line, so it's important to define and do the digital ditching that the software permits us to do. And in this case I think that traditional impression is not so easy to take, because you can see that all the abutments are very close to each other. We are in a posterior position, a lot of saliva. It's not easy to take a well-defined traditional impression in this kind of cases, and I think that digital solution is giving you a possibility. Of course it has to be done in a very precise way, and you have to have a protocol, a scanning strategy to achieve this kind of scan. But moving on with the case, we can see our framework. Our framework is in this case is a monolithic zirconia, and you can see that the function is a replica of our temporary, is a replica of our temporary and of what we scanned before. The only layer, vestibular layer, that we left is for the ceramization, for the veneering of the ceramic, in order to give a more aesthetic to our patient. And moving on with the case, you can see here the final restoration in place. You can see the dynamic movement in the central picture, and you can see the occlusal view of the final restoration. This is another case that we have done with Luca and Matteo Dondi, and I think, as I was telling you, is a multidisciplinary approach, because as you can see here, before doing the prosthetic part and the periodontal part, we have to treat these teeth, and we have to do and have nice root canal, nice rebuilding of this abutment. And here you can see the before and after of this patient, before the periodontal and prosthetic part, and on the right side you can see the follow-up of the control of the nice fitting of the crowns, and everything looks nice for this patient. To conclude, let's see how in more complex cases in full arch rehabilitation are entering the new technology, because nowadays most of the patients that are entering in our office are this kind of patient that are potentially dentulous. These patients are afraid of losing all their teeth, and that's why, and that's the reason, because they arrive at such stage of their mouth, and because they are afraid of losing their teeth, but especially are afraid of wearing a partial removable denture or a complete removable denture. And so this is exactly what they are asking us when they are entering in our office. Please, we do not want having something removable in our mouth, even only for one day. So especially for this kind of patient, it's very important to have a multidisciplinary approach. It's very important to coordinate with all the branches, with all the professionists that are working in dentistry, that are critical to solve this kind of case, from the professional hygienist till the dental technician. But what is more important is that we have always to have in mind that the patient has to be in the middle of this treatment plan. Alessandro and myself, we have a philosophy that we call modern treatment plan, that as of course clinician goals that are the classical clinician goal, for example surgical, prosthetic and ergonomics, but we think that it's important to have in mind also the patient goals, and especially that the patient, yes, wants a life quality at the end of the therapy, but especially he wants a life quality during the treatment plan. And how can we achieve it? We can achieve this by doing effective provisional, reducing surgical step, overall treatment plan, having always in mind the patient request. For example, especially in the potentially edentulous patient, we do not want have them wearing a removable denture even for one day, even for 1 month. We always want to try to have something fixed in their mouth, and of course we want to try to reduce the surgical step as much as we can. To do so, we have a protocol that has been published in 2013 in 2 publications, one together with Dr. Davide Romeo and Professor Christian Stapper from the University of Maryland, and one also with Team Atlanta, in where it is explained the protocol that we have for this potentially dentulous patient. Let's take, for example, one of the patient that is inside these two articles, these 2 publications. This is Sergio, 56 years old. He entered in our office in 2011. As we always do for every patient that we visit for the first time, we start collecting information. Most of the information are achieved from the photographic setup, in where we can do the macroaesthetic evaluation with the facial analysis, the mini aesthetic evaluation with the dentofacial analysis, and the microaesthetic evaluation with the intraoral pictures. And from here we can start seeing a lot of things. For example, we can see that the dental midline is canted toward left, toward right. We can see that Sergio has a low-high smile line. We can start listening especially to our patient request and our patient chief complaint. He was complaining about the upper work restoration, that he was always coming off from his mouth. He wasn't happy with the color, he wasn't happy with the way he was smiling. And on the other side, he was a patient that he was very positive. He had a positive attitude, and he wanted really to solve his problem, and he was very compliant. Beside the photographic setup, it's important also to collect this kind of information, so a full mouth x-rays, periodontal evaluation before and after the professional hygiene, and also the study model evaluation. From these three things we can collect even more information. We can see, for example, the problematic in the lower arch of the remaining abutments. We can see that there are two implants that are failing on the maxilla. We can see that it's not only an aesthetic issue, but it's also a functional issue. Look at, for example, at this particular picture of the study model, where you can see how the function is completely off to this patient. And of course, it's important the periodontal evaluation to evaluate also the compliance of the patient during the first part of the treatment, that is called preliminary treatment plan, in where we do a professional hygiene and where we do periodontal evaluation before and after this hygiene. So once we achieved the diagnosis, we start thinking about the treatment plan, and this was the treatment plan that we decide for Sergio. Full arch implant restoration both on the upper and the lower jaw, with 4 implants, 2 tilted and 2 tilted in the more distal areas, and 2 axial in the central area. And you can see that we decided to go for a screw retained zirconia oxide restoration with monolithic in the posterior areas and an anterior zirconia restoration layered on top with veneered ceramic. Those are some pictures of the surgical plan, and you can see how important are all the prosthetic components in this kind of revitalized solution. We have a multi-unit angled abutment that are helping us, prosthetically speaking, in compensating the angulation, the tilting of the most distal implant. You can see the before and after. You can see the x-rays, and in where you can see our treatment plan. You can see the implant in place, you can see the suture, and with our protocol the patient is staying like this for 24 hours, because we want to give to our lab technician the correct time to build a provisional. In fact, as it has been the leitmotif of this digital webinar, temporization is critical not only in the traditional protocol, but is very critical also in the digital era. But why we want to do this kind of provisional, and why we want to do a reinforced provisional, especially in this kind of cases? Because also the literature is telling us that the most frequent complication reported in this kind of patient was the fracture of the acrylic prosthesis. Metal-reinforced frameworks, in fact, are significantly stronger than acrylic, and because they provide more rigidity. So in this kind of patient, in where we go for a surgery, in where we go for an immediate implant placement and loading restoration, we want to have a metal-reinforced framework inside the provisional. And of course we have to study where are the weaker areas, and again the literature is telling us where these weaker areas are, and usually are close to the temporary abutments of the anterior implants. So we have to think how to strengthen them. We have to know all these kind of things in order to prevent some problematic during the treatment plan sequence. And here you can see the great work of one of our lab technicians, Laura Morselli, that is taking her time in doing all the characterization of the provisional, is working on the function of the patient, we are working on an immediate implant provisional, so the the occlusion has to be carefully checked, but not only, as I was telling you, the function, also the static, taking air time to do all the characterization, the dental characterization, the enamel characterization, because most of the time is in the digital era, in the modern treatment plan, we have to be able to give a nice, a beautiful restoration that is working to our patient also at the provisional, because the provisional would be the copy of our final the final restoration will be the copy of our provisional. And here you can see the provisional on the models before screwing him in the mouth of the patient. Here is 24 hours after the surgery. You can see in the intraoral picture that are still the stitches in the mouth of Sergio, but you can see on the right picture Sergio that is smiling, and he had no pain. We want to have a surgery that is the most atraumatic as possible, because this is how we want to see the patient 24 hours after the surgery, smiling with his nice provisional in place, with no bruises, with no swelling. Because, as I was telling you, the modern treatment plan approach has to have in mind the patient and the life quality of the patient also during the treatment plan sequence. But let's go back to the digital solution, and let's see what we did for Sergio. We are doing some trial also for this kind of full arch rehabilitation, large full arch rehabilitation. And in this case we place the match holder in place. You can see here the ortho retractor, and then we took the digital impression also of this kind of patient. We are still working on it. We think that right now is still too early to go completely digital for this kind of patient, but this picture is very nice. This slide is very nice because it's giving you all the digital workflow when we're taking the digital impression. You can see that Alessandro is looking at the screen. You can see how clinical the movement are slowly, and you can see what is looking on the software. But already now in this kind of patient we can save some steps by taking out the provisional, screwing in the study model, and taking this scannerization, because we can send this scannerization to the milling center, to our dental technician, and the milling center will give us a prototype that we can try in the mouth and do a sort of aesthetic and functional try-in, and we're gonna see it in a minute. But now let's focus again on how this Intra scanner is working. You can see how the 3D model is generating. Right now we are closing all the black holes. You will see you are the step 3 of our protocol of scanning. Let's see in the lower temporary, you see we are closing all the black holes. You can see all the colors that are telling us what we are doing exactly. You can see we are taking the byte registration, and then we will send everything to the dental technician and then to the milling center, closing the black holes, and then when we are happy with it, we process the file and we send it away. And as I was telling you, we are still working on this, in the sense that so far it's still early for somebody that just bought the intraoral scanner to go for this kind of restoration, because especially for this kind of complex rehabilitation, you have to have a scanning strategy. Because, for example, look at this picture on the left side. In this full arch rehabilitation, you can have an error also of 250 microns, but there are how can I say, protocols that are helping you to avoid this kind of errors. In fact, we are studying that just by sectioning the scan, so by taking little pieces of the patient's mouth in the full arch rehabilitation, you can see here on the right side in this free section, we can decrease the average error in a very important way. So again, scanning strategy is critical to be more precise. And here we have our prototype that arrived in our office. We screw it in the patient's mouth. We try the function of the patient. Remember that we want to go for a monolithic zirconia, and especially in the posterior area, and we want to try the function in the mouth before sending everything to the milling center. Then we're gonna go also for the static train, in where we can start taking information about the occlusal plane, about all the parameters that will help us and the dental technician to for the final restoration. Then everything is sent back to the lab, and Luca in this case can work on the function. Remember, this kind of big rehabilitation are, yes, for a patient aesthetic issue, but if we want this rehabilitation to have a long-term survival, we need to work on the function. And you can see here that Luca is working on the function, is giving a sequential guide to the restoration, using all the traditional parameters, as for example the pantographic registration. When he's happy with it, thanks to the new scanner that are in the market, and this is the evolution, he can scan what he did, and he can have a nice work at the CAD. You can see here, for just to give you an example on how these new scanners are working, another restoration that we did with 6 implants with the scanner that is taking all the information. This information will then go to the software, will then go to the CAD, and Luca and Matteo can work on the final restoration. This is Sergio again, and you can see, as we said at the beginning, posterior monolithic zirconia in the anterior area is reducing and giving some space for the veneering ceramic. Here it's very important to underline how this new technology changed and the precision of the dental technician workflow, because just by clicking a button, he knows for sure how much he reduced the framework, and in this way he can control all the bakings of the veneering of the ceramic layering, and he can be more precise. This is those are the frameworks that are coming out from the milling center to the dental technician lab. You can see how stable are these pieces, one on top of the others. This means that the work that Luca did of the function really worked it out, because look how stable they are, just put one on top of the other and they are not moving. From here, Luca can start with the pigmentation bake. He can start giving the characterization of the final restoration. He can control with only 2 bakes the veneering of the layering for the aesthetic area. He can start giving his artistic knowledge, and you can see here how the tradition is combining with the digital. This is very important. Look how the function, especially in Sergio, has been checked carefully, and look how it changed from the beginning of the study model on the left side to the right side, in where we have the 2 arches, one on top of the other, characterized and functionalized in the most precise way that we can. And here we screwed in the upper restoration to Sergio, in where we can see all the artistic talent of Luca. We can see that also in these cases the white and the pink aesthetic are blending together. All the aesthetic parameters are inside these pictures because he worked on the gingival symmetries, he worked on the dental proportion, he worked on the correct dental axis, the incisal embrasures, everything as at his place, aesthetically speaking, but we saw also that functionally speaking, aesthetically has been checked carefully. And here we have the before and after of this revitalized solution. You can see how Sergio changed radically in a in a short period of time, because this kind of rehabilitation, the immediate loading rehabilitation, is giving to the patient the possibility of passing from a picture on the left side to a picture on the right side in a relatively short amount of time. Here are some pictures of the smile of the patient, because this is exactly what the other patients that are not dentists look every day, how the patient is smiling. It's important always to have a final x-rays in where we can see that everything is working well also from under the implant aspect. And you can see here the timeline of this immediate protocol that in 9 months permitted to give to Sergio a big increase to his quality of life. And we see that the path followed to achieve this final restoration is the same important for us, for the clinician point of view, the same important as the final result, that of course is the most important thing for Sergio. And you can see here how important is always to take picture of the smile. In this slide you can see a sort of dynamic smile of our patient, because again, when he's walking outside the dental office, the normal people is looking at him while he's speaking, while he's smiling, and this is where the final restoration has to work. And of course it's important to take this kind of picture, but it's important also to carefully check a video in where we can evaluate the dynamic movement of all the facial complex of our patient. It's always important to see the facial complex, not only focus on the smile and on the teeth. The teeth has to work inside the face of our patient. And this is the 1 year follow-up. You can see always important to have the static black and white with the full mouth x-ray, because we want to see if everything is working well, and of course taking some intraoral picture. This kind of patient, you can find a similar patient in a very nice event that has been created by Maurice Salama, that invited us with some other team all over the world in this World Cup Team Dentistry that is going to be presented in a special edition of the journal of the AACD, and is gonna be presented also at the beginning of next year on Dental XP with some webinar. For what concern us, we will present a case step by step, restore with the CAD-CAM, and we can see all the benefits that the CAD-CAM is giving us and gave us in that kind of case. But I suggest you to come often to Dental XP, to go to the site of the AACD, because this World Cup Team Dentistry has been is a very nice opportunity, because besides us you can see other team from all over the world. For example, Dennis Tarno and Stephen Chu and Christian Kochman and Marcelo Calamita, and you can see how is the team approach to solve this kind of patient. So let's now conclude, and of course we are at the end of our learning curve, and at the end of our learning curve we are able now to give you some benefits and some limitation of this new tools, this new solution, this new digital solution that is the intraoral scanner. And as we can evaluate both from the natural dentition point of view to the prosthetic implant rehabilitation, single implant, full arch rehabilitation. And the benefits, of course, are that we have the possibility to rescan in real time if there is something that we don't like. This is something that is not possible to do with the traditional approach. We increase the patient comfort, and in the modern treatment plan approach, in where our patient is in the middle of the treatment plan, it's important. We can have the possibility to have multiple sessions of the same impression, another thing that is not possible with the tradition. And what we saw is that is also very appealing to the patient. So they are starting to look you with different eyes when you're starting to explain him that you're doing this particular impression that is digital, that is something new, and so this at the eyes of the patient it's impressive, and this is something that is not to underestimate it. Speaking about the implant restoration, one of the big advantages is that we have we can eliminate all the prosthetic tolerance that we have in the traditional implant impression. It is not necessary to solidify the mid shoulder together like we do, for especially us, we do with the traditional approach. We have a simple duplication of the sulcus, and we have no stress in the implant mid-shoulder interface. So as you can see, we have a lot of benefit, we have a lot of advantages by using this new digital solution. Of course there are still some limitations. Of course you need to have a learning curve. A learning curve because this is something new. We are used to the tradition, and so we have to study a protocol that work in our end to be performing, and of course this initial learning curve is time consuming, so this can be seen as a limitation. And also posterior areas are more difficult to approach, especially at the beginning if you're not used with the intraoral scanner. But every day more we are increasing the potential of this instrument, and I think this is the future. This is the future, but it is already the present, because you can see in this, you could have the possibility to see in these two webinars that there are a lot of things that already now can be done, and in the with the help of the new technologies. Of course, it's important in all the cases that you have seen today, is not today and in March, is not that the new technologies changed our life in the sense of okay, we have the new solution, the new digital solution, and we can restore this patient easily. The new technology are a tool that are increasing, and our possibilities are a tool that are increasing our possibilities, but still critical is to have a standardized protocol that we have to have from the beginning to the end whenever a patient is starting to do something in your practice. because only in this way, in our opinion, you can achieve final restoration on natural dentition, in aesthetics, in aesthetic area, on single implant rehabilitation, in specific cases, in full arch rehabilitation. Yes, the new technology are giving us a lot of advantages, but having a standardized protocol is still the key for success. And in order to conclude, we want to just to tell you that still now, clinician and technician professional background has to combine with the new technology. The new technology are not the solution for everything, because only by combining them with your traditional and professional background, you can provide to your patient a better aesthetic and functional result. Of course, you have to know in knowledge, you have to know in depth the knowledge, you have to know in depth the characteristic and the properties of all the material that you're using in your patient's mouth. And of course, you have to perform carefully all the clinical procedures that are still of utmost importance to achieve satisfactory result. This, I think, are the take-home message of this webinar. We have advantages with the new technologies? Yes, we have a lot of advantages, but we have to combine them with your background, with your knowledge, and with a standardized protocol. This is very important. And we have this philosophy. We think that dentistry is a team sport, and we want to thank all our co-workers, all our assistants, all our dental technicians, because without them we could have not been here giving to you an overview of our digital experience. Our team workers are helping us also in the our education that we have on a daily basis in our practice. We do different courses, prosto courses, periodontics courses, and implantology courses, both from Italian and foreigner residents. We have the possibility of doing a live surgery, full HD. For example, this has been taken from the last periodontal course that we did 2 weekends ago, and also resective surgery. And you can see that you can follow the patient from the beginning, from the very beginning, from the probing till the final suturing, passing to how to elevate the flap, how to reline the temp, how to prep the teeth intrasurgically. And so you can have all this overview, and you can go and try what you just saw on the surgery, on peak jaws. We have practical hands-on, and you can see here Alessandro and myself inside of one of our periodontal course. To anyone that is interested, you can send me an email, because we are not doing only practical hands-on, but we are doing also cultural hands-on. We are lucky to work 5 kilometers from the Ferrari factory, so we always organize for all our residents a guide visit to the factory, to the Ferrari's factory, in where you can see how the Ferrari is built from the very beginning to the end. And so we want to thank you for your attention. We want to thank Dental XP and all the team to having us invited once again, and we want to remind you to subscribe to the next Dental XP Global Symposium in Miami. Thank you very much.